Welcome to the Functional Code, your go-to source for decoding optimal health. Join Dr. Addy and Dr. Jace as they break down the science behind pain, performance, longevity, and more, making complex concepts easy for you to understand and apply in your life. Your journey to a healthier you begins with understanding the Functional Code.
Disclaimer: the content provided in this health podcast is for informational purposes only and is not intended as a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have heard on this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Reliance on any information provided in this podcast is solely at your own risk. The creators and hosts of this podcast are not responsible for any actions or decisions you may take based on the information presented.
Welcome back, everyone, to the Functional Code, episode 15. We're talking pain today. This is going to be a big one, Doc. I know I've been excited. We've been pushing this one off for a while, mostly just because there's a lot that can go into pain. But today we got a really good one for you. I am Dr. Addy.
And I'm Dr. Jace. Today we're going to be going over a bunch of different fun, interesting facts about pain. We're going to dive into the different types of pain, where it's perceived. Is it more at the skin, body level, or is it in the brain and the perception of? Then we're going to get into the gate control theory on how everything kind of works together, and then combine that to body versus brain. We're then going to get into the psychosocial model on how environmental factors, how your emotions play into the pain throughout the whole body and how that's perceived. And then we're going to dive into some other tools, some other studies, so you know how to combat these pain feelings that you may have, especially if you get stuck in this rut for a period of time. So as we go through, Doc, interesting facts about pain, and I'm super excited on this one. There's a lot of fun, different things that we can touch on, and I think we're going to hit the huge array of pain itself, but interesting facts, Doc. What you got?
So to get started, I wanted to just bring up some light facts on pain. This is one that's one of my favorite. It's just because I don't think people truly understand how frequent pain will arise in someone's life, and especially with certain manageable pains. So in regards to low back pain, that's probably going to be one of the most experienced conditions of pain, and that's 80% of individuals will get low back pain in their lifetime. And when you think about that, that's just the best perceived estimation of study. My guess is it's going to be almost everyone. There will be a point in time, if you live long enough, you're going to have back pain. And back pain was the one that really started this whole thought process and cycle change of pain. That's really where they wanted to develop the biopsychosocial model, because back pain is what they now have found to be way more multifactorial. It's not just physical now. They understand that there is a lot more psychological effectors of pain when it comes to back pain. So this is when the opioid epidemic really took off, and how painkillers were then given out for back pain. ER visits are still, I think, top 3 is low back pain now. There's just so much to mismanagement of back pain. And so to kick off the podcast, I kind of wanted to just really hone in on how we still have so much work to do when it comes to musculoskeletal pain, and how often people are going to have this. And of course, we're still dealing with how the mismanagement is not appropriate, and the other things that people can now do to manage this, and things that they need to do to manage this more appropriately. So the things that I wanted to bring up is, first off, pain perception is subjective. So what that means is two people could experience the same injury, let's call it a sprained ankle, and those two might describe the pain differently based off of the experiences that they've had in their life, the emotions that they feel towards it, even cultural backgrounds. And what that really means, what's up, buddy?
Sam. Good job.
So what that really means is, when it comes to pain, how we communicate pain to one another is important, because it might be experienced differently between two people. And especially between physician to patient, it's important, because you might have 2 sprained ankle patients in a row who might give you differences and feelings, and you got to be able to make sure not to either minimize or allow them to minimize their feelings or pains based upon just how they're subjectively feeling it. And this comes not only with a sprained ankle, but chronic pain or patients experiencing a fracture, really anything. It's important to note that the subjective portion of things can only be assessed so much, and then there are other things that need to come into play when you're understanding pain. And as people age, perception may change. Usually older adults experience chronic pain due to conditions like arthritis, or they even have a higher pain tolerance compared to younger people, just because the receptors have usually been dampened over time and they're just getting used to what pain feels like. And that's also important to note, because as we age, just because we feel less pain doesn't mean it's still not important to understand what pain is arising.
Yes.
And that's where I think a lot of people usually throw out the "I'm just getting old" excuse, which, in my opinion, when patients say that in the clinic, it's curse words to me. Like,
so overused.
I really do hate that excuse, because it's just a way for us to put a ceiling on humans, and especially potential of humans. But we don't have to succumb to this idea of aging, because what we'll find is, just like I had a patient, she was 96 years old, she ran a marathon. When you start having those beliefs, then you're going to limit yourself and you're not going to be able to push yourself to those kinds of feats.
True.
Lastly, genetics, age, gender, even past experiences, like I just said, can influence an individual's sensitivity to pain. If someone has sprained their ankle before, then their idea of that experience is going to change, where the first time they had the sprained ankle, there was maybe more fear, more pain, but the second time they understood what was happening. So maybe now there was less of an impact or less of a pain response. And these are things that can actually make a change. Doc, I know you had an interesting fact about just the genetic mutations when it comes to phenotypes of redheads.
Yeah, so before I dive into that one, going back to just even like the past experiences, like when they have that pain come up, or like they roll the ankle, what is their perception of pain at that time? And some of this will be like, let's say for example, soccer player, they're in a tournament looking to get to the championship, they roll their ankle, they're not able to perform, compete, they're taken off, the team loses. That perception of how that individual feels at that time, and the amount of anger involved with that situation, the amount of stress, all will play impact on the memory system, which then feeds directly to the brain, and that then sends a signal of not only pain, but also if that individual would then go again and sprain or roll the ankle, those similar feelings will then get brought up later in life.
Exactly.
So there's so much in terms of pain science that, quite frankly, we're still learning.
Yes.
But there's a lot. So when I'm diving into redheads, this is kind of interesting. Only redheads, they have a gene mutation called the MC1R, or melanocortin 1 receptor gene, and that gene helps regulate not only the colors of the eyes, the skin, the hair, but it also helps influence a different protein that gets excreted called the POMO, or the propionmelanocortin, which then has a huge connection between the pain control centers, and that helps regulate like the thalamus and the connection to the brain. Especially anesthesiologists, they have to give out 20% more anesthesia and also pain meds when performing operations on any people with redheads. So
20%, that's crazy.
Yeah, and that's fascinating. Now, I'm sure they also have to play in the factor of males versus females too, because there's been other studies done that shows that males have a lower pain threshold than females, and we were talking before the pod on this one, and it makes sense, especially for females giving birth to humans, and how that's had to adapt for generations, years, thousands of years.
Do you want to bring up the Mythbusters thing? That was interesting.
Thank you. So the Mythbusters, they did a fun case study trial to where they had men and females put their hands into an ice cold glass of water, and they had them take their hand out if the pain was too much. They first said, okay, let me know when you start to experience pain, and then take your hand out if you can't handle it anymore. And 3 minutes was the max, because obviously we don't want individuals to create and cause any frostbite to the fingers. And I'm sure they also did the screening so the individuals don't have Raynaud's or a condition for poor vasculature to the distal extremities, fingers, toes, what have you. So what they noticed was men reached the pain threshold first, or they experienced pain sooner, and then they also took their hand out of the ice cold water sooner compared to females. There were some males that got to the 3-minute marker, which is the cutoff of going to the experiment, but females lasted way longer and way more of them, which makes a lot of sense.
And like we had said before the podcast started, it would make sense that women have much, much higher pain tolerance. If they're about to give birth, they would probably want that amount of tolerance.
Yes.
So there might be some evolutionary creation with that as well.
Yeah. Now, as we found out about the pain, we're going to dive into some more of the specifics. So there's different types of pain, and that can be experienced in numerous amount of ways. In terms of nociception, which is how the body regulates the control centers just to protect not only the skin but other limbs, and how that gets kicked up to the spine, to the brain, and how is the brain's perception back down. And there's a reflex involved with some of this as well. Doc, let's dive into some of the types of pain in terms of nociception, neurogenic, neuroplastic, cancer, psychosocial, referred, phantom. Like, let's go into some of these.
Sure.
Yeah.
So, like Doc said, the first type of pain, it'll arise from the nociceptors. So nociceptive pain is due to any type of alteration or potential tissue damage around the nociceptors, and that then feeds back into the spinal cord, into the brain, to allow us the ability to understand that there is something wrong with either the skin, the joint, the muscle, anything that has nociceptors around it. This is called first somatic nociceptive pain. Again, it involves skin, muscle, bones, joints. But then they also have what's something called a visceral nociceptive pain. It originates from the organs, but the organs don't actually have nociceptors. We have this interneural connection with the organs to nociceptors. So what actually happens, and this is something that I know you guys can understand now, just given I'm sure your experiences, but when, let's say you have stomach pain, it's not actually your stomach that you are feeling, it's the nociceptors around it, even in the skin of the stomach. And what can also happen is because you don't have nociceptors in your organs, you'll get referred pain somewhere. So a good example of this would be men, pain in the testicles. Because you don't have nociceptors in your testicles, if you've ever been hit there or have had any issues there, it comes up into the stomach. And that is because your body tries to put signals as close to the organ as possible, but sometimes it misfires or it doesn't have the actual ability to put it where it is. In women, this would be the ovaries. As you're going through your cycle and menses happens, yes, sometimes you'll have stomach pain or you'll even have back pain. And it's just because, again, the nociceptors are trying to fire to explain what's going on organ involvement-wise.
Same thing with even kidney stones, right?
Yes.
Like, as the stone goes through, there's a lot of pain usually on the sides.
Yep.
And we can go on and on, I feel like, with this one. A lot of these receptors will feel not only if there's something going wrong with that organ, but also just pressure. So, like, let's say if someone ate too much, the space and the pressure inside that organ can also regulate more for like the overall feeling on the skin of like stomach issues, pain.
And it's important to note because stomach issues are usually put in quadrants. And so you have lower right, lower left, upper right, upper left. And all quadrants are actually very important to note where, because it usually ties to a specific organ when it's having that area of pain. And as physicians, we actually take note into that. So when you are having stomach pain, sometimes it's good to note, are you having it more on the right side, more on the left side, more up or down? Because it then tells us a story. And we're going to get to the understanding of why pain as a story is such an important thing to note.
That's beautiful.
Yes.
Absolutely. And going back to the somatic nociception of pain, especially from the muscles, joints, from that realm, that communication back up to the brain is so important.
Yep.
So oftentimes if someone has pain, they often think, oh, let's rest, let's not move. That's where everything can more or less either one, the muscles and tissues will tighten up, or two, the area will guard with a lot of tightness that can last for decades, years long. And to combat that, you want the proper signal from that damaged area back up to the brain. It's much the same, like if you injure any area, it's almost like a mathematical equation in terms of the body was either able to absorb or dissipate force or handle load against gravity, and the tissues gave out. And when that happened over time, you might not experience right away, but as time goes on, that signal to the brain then gets changed, altered, depending on, like we said, the experience, the motions with that, but how you can go about getting that under control. The start of the process is movement, pain-free, because when there's a lot of tightness in the area, it also restricts blood flow, vasculature, blood flow in and out, the lymphatic tissue, and thus it doesn't allow the healing to take place. So that's where some of this stuff, in terms of old injuries, can play a factor, whether it's, if you injured any area and is there pain or not, either or it can cause either compensations or it can cause tightness, which then can hold on for decades long. That's just an area that at the end of this podcast, we'll get into a little bit more on more specifics with that, but yeah.
No, that's great. And
we'll add on.
I'm glad you brought that up, because we are going to get to the theory of just affrontation and why that can be such a great way to manage pain. And I'm glad you brought that up, because I'm excited to talk about that too. The next one we have is neuropathic pain, and that's damage not to the nociceptors but to the nervous system. And this usually presents with a worsening pain or different types of pain like tingling, numbness, or paresthesia. Things such as neuropathy, neuralgia. If you've ever had trigeminal neuralgia or postherpetic neuralgia, if you've had shingles, you'll know that it's a much more stingy, acute, local, tingly numbness, sharp, and that's the extent of the pain that you usually feel when you have neuropathic pain. And neuropathic pain is unfortunate because when we do have a damage to the nervous system, it can be hard to heal. And this may even be more long-standing or chronic, even progressive, as it just gets worse and there's nothing that we can do. And that's unfortunate. Things like MS, these types of progressive neurological diseases.
And even before we get into that, like even understanding the types of pain, so like what Doc said, the numbness, the radiating pain, the tingling discomfort, even certain aspects of like sharp pain, achy, dull, all that tells from a practitioner standpoint on what could be going on. But in terms of neuropathic pain, that, like Doc said, has more of a tingling numbness feeling to it versus the nociceptive pain, which can either be sharp pain, dull, achy, sore, which it's just different communications from the body to the brain, how the brain perceives it. But
yeah, that's great. Next one is nociplastic pain, and this one it's still an ongoing area of research because we really still don't know why the body has this kind of pain. And you'll know when I talk about fibromyalgia, even other types of conditions which have a increased central sensitization of the body. And I won't go too deep into central sensitization. We did a great job of going over that on the Jaw podcast. So if you guys want to jump back to that, please do. What the theory of central sensitization is we have this basically altered status of pain, communication, let's say, in the body, and it could be absolutely normal stimuluses that can happen to your body or throughout the day, but you perceive it as painful. Fibromyalgia is one of them. And this altered nociception without any clear evidence of tissue damage is nociplastic pain. We don't have a broken bone, but we feel like we do. We don't have any real objective visual change in the skin or movement, but this patient is feeling pain in this area. And it's unfortunate because it's tough as a practitioner. When we do an X-ray, MRI, we go through all of the tests and it's clear, well, now where do we even get started? But this is where the psychosocial model of pain now comes in. We'll get to that in a little bit, of how pain is so much more than physical alteration. And when people really understand that, those are the kinds of conditions that can respond to more anxiety-based treatments, stress-based treatments, psychological treatments. Doc?
And I know we had a patient in terms of this type of pain to where she came in, she was doing just fine. All of a sudden she bent over, she heard a pop. Now she is grinding with certain movements in her back spine. We had her send her out for MRI, came back clear, there's no disc irritation. And then she gets on pain meds, and then there's a whole cycle on that, and we want to take her off of that because the reliant factor of how her perception of that more than likely is her thinking there's probably some damage, either from a past accident, injury that she may have experienced previously, and how she thinks that these are related probably subconsciously. But that's where, like, not only with the fibromyalgia, it can also be in other areas of the body. And during the interesting facts part, if there's a rolled ankle, how is that perception as each time that individual rolls the ankle? So this plays a factor in terms of how we perceive the pain, but yeah, we'll see where we're at on that one too. So
no, I like that you brought what you experienced that patient, because I think it's important to note she did bend over and hear a noise, and that's scary.
Yep.
And she had pain with that noise, and now she's thinking, what did I break? What is going on with me? I probably just tore a muscle. I may have broke something. And now that is going to be tied to figuring out what is wrong until I get better. And what's an unfortunate with her case is we did all the imaging and it showed there was no injury. And the noise she probably heard was maybe just the bone moving enough to cause a cavitation, or in our world as chiropractors, as a crack or a pop. And those are not harmful in any way. But she tied so much of her pain to a noise which she thought of as an injury. And now she's thinking, well, if the MRI was clear and the x-ray was clear, what else is it? Because I know there was a noise and I know there was an injury.
And it still hurts.
And you're going to continue to catastrophize and fear. And there are just these times you get caught in a loop of this psychological effect towards pain, and you can't pull yourself out of it. And that's where you need to have acceptance and accept that, yes, the noise happened, but there wasn't an injury, and I am okay, and I don't need pain medication, I don't need surgery, I don't need to go down this route of what I have observed in the medical model over time, which is when something bad happens, I either need a drug or surgery to get better. But if I don't get those things, how am I going to get better? And I think these unfortunate cases happen all the time because there just isn't proper education with pain, and providers just choose to skip over that because it takes a lot of effort to communicate that with patients.
And I think just what Doc said is just a tool in itself. It's just sitting there observing the pain, the education of there may not be tissue damage, there might not be any damage at all to the body, but how the brain thinks that there is, and that disconnection. There's books out there on some of these topics, but in terms of you just paying attention to that pain, just sitting there with no other stimulus coming into your body, just pay attention to that pain. Give it a good 15, 20 minutes. Yep. Does that pain diminish?
Yep.
Does that change the signal or how you feel with that pain?
Yep.
Oftentimes it diminishes significantly.
Yep.
And that's how powerful the brain is.
For sure.
So
that's
yeah.
So true. So true. We have cancer pain just caused by cancer itself. This can be due to nociceptive changes, neuropathic changes, or mixed. We don't need to touch on that too much. Psychogenic pain, like we talked about, can be due to psychological factors. The other one that I kind of wanted just to touch on was phantom pain, and that is pain perceived in a limb that was amputated or lost, which I think is a whole other emerging theory of pain research, to think that the body can still, and from what I've read and heard of patients who have had something like this happen, they do still feel like they have the limb and that there is pain arising from that area. And that is just in itself a characteristic of how strong and crazy the brain is when it comes to literally giving you almost this out-of-body experience because you don't have it physically, but it's there. You are feeling something technically in space now. If that's not something freaky to where you can now take that theory and think, okay, the brain is now letting you experience a feeling of something that is away from you or outside of your body. What else can the brain do that's away from ourselves, and what can you feel away from yourselves? That's where you can get into the whole idea of empathicness and getting to actually, can you actually feel what other people feel? And there's actually research on this. There are people that what are called empaths, where they have the ability to feel more in regards to other people's pain. They did a study on this, and they put people in a room and they showed people getting injured. And the empaths actually had a higher output neuronally of pain felt and experienced pain, basically meaning there are people out there who can feel other people's pain. And that is something that's scary in itself, because if you do have the ability to connect to other people at a higher level, and knowing that you do that, you need to make sure that you are protecting yourself, because these empaths unfortunately become a sponge and they take on a lot of other people's feelings, emotions, pains, and you'd be surprised at how many providers are empaths. And that's why we got into it in the first place, is because we understood that we can do that. And we do have a better ability to read people and understand how to help them and what they're feeling. But yeah, I always thought that was interesting.
And I didn't even know you were going to bring that up, and I feel like I'm this exact same path, because like anytime patient comes and sees us, personally, I try to put myself in the exact same shoes, mentally, physically, so it's just easier for me to help treat people. But knowing, like, let's say they got in a motor vehicle accident, well, how did it happen? And you can put yourself through that experience somewhat, like mentally, and understand, okay, like if someone came from the side, how fast were they going? Were you aware of that? Are you bracing? Are you guarding? If you weren't aware of that, the impact, let's say it's from the side or behind you, and how that can affect the whiplash. And then the all of a sudden impact as well can have the fear top down in terms of what just happened. Am I still alive? And then as time goes on, things can tighten up, and you can almost, knowing that all these steps are a factor, you can almost experience to a certain extent what that could be like, just even experiencing some of these similarities. So I can, definitely makes a lot of sense. But
empaths think that way too.
Fascinating.
They do. They're constantly, even subconsciously and very quickly, putting themselves through that without even knowing they just did that. And what was funny is, well, I didn't even think I'd talk about this, but I watched a movie last night with my girlfriend, and it was called Glass, and it is the third movie in a series of M. Night Shyamalan films, and it's about, the first one was with Bruce Willis, and he couldn't feel pain. Like, that was the first, and it made him superhuman. The second one was Split, which was a gentleman who had multiple personality disorders, but one of his personalities was superhuman, almost mutant strength, and he became a different mythical figure when he was this personality. And then the last one was Glass, and it was set upon, in the first film, there was a gentleman, Samuel L. Jackson, who had osteogenesis imperfecta, but he was incredibly smart because he couldn't do much, but he then chose to, instead of, no, I couldn't move, I'm going to think. And so but what I wanted to talk about in terms of empathy was, there was a power that Bruce Willis had, which when he touched someone, could experience and feel what that person has done in their past and present. And so he was able to go around, touch humans, and then actually figure out if they were a bad person or not, or if they've done something bad. And then he would then take vigilantism and try to, again, find the criminals. But in the last movie, these three individuals were put into a psych asylum. Spoiler warning, by the way. Sorry about this. I should probably do that. But basically, they were trying to be told that they were not superhuman and that they just had a form of delusionalism. And the psychotherapist was talking to Bruce Willis's character and basically saying that, okay, do you just think that you are a world-class empath? And that when you go to touch somebody, you've already subconsciously read everything about them and you know whether they are a bad or a good person. And in the case of this one scenario, the Bruce Willis's character was walking by this bad guy sitting next to him, which is the multiple personality. He had tried to go and find this guy to beat him up. And he walked by him trying to find him, and he grazed his shoulder. And he was able to then visually see what that man had just done like 30 minutes ago. And so he knew it was him. It was the guy he was trying to find. So he went to the area where he was to try to save these people that this man had captured. And in that scenario, the psychotherapist was like, okay, I know you were able to find this man you were trying to find, but she had took out this man's clothing that he had been wearing before he got into the psych asylum, and it had dirt on his pants. And she said, just maybe, did you subconsciously see the dirt on his pants? And did you see that he was acting a little funny and changing as you walked by, and you subconsciously picked up that maybe he had multiple personality disorder, which you knew. So you knew he had that, and you knew that he had dirt on his pants. So you knew where to go, and you knew that he was the bad guy as you walked by. You didn't need to touch him and experience this superhuman power that you say that you have. And then he started to actually question whether or not he had superhuman powers. But to basically end on that is, there are just people who maybe can read people so dang well that they don't even realize that they're making these small, subtlety, detailed visualizations and informative reaches, and you're able to then perceive that in a way that no one else can. That is what empathy maybe is. And maybe that's the best way that I can explain empathy, because I haven't met people who can even feel people coming in a room not even knowing. I met people who have been able to say that they knew I was in the room. They knew I was in their house before I even come to see where they are in the house, because they can feel things. And I don't know what that is. I don't know what that perception is like, because I don't have that. But it's crazy how this body of ours is able to pick out things in space versus our own body.
Imagine if that can be trained
over
time, depending on, I'm sure it could be different if you have these traits that they can be trained up, but if you don't, maybe not. Like, for example, I have a weird high sensitivity smell to peanut butter.
Okay.
Like, I've been supposedly allergic most of my life, just did an allergy test, and apparently I'm not, but anytime within, probably about at least 20 or so feet, I can smell anytime peanut butter is around. And that's just one sense. Imagine if there's a different sense of, like you said, a person coming into the room, is either the energy, is it the vibrational frequency, is it the smell?
Was it wind? Was it yeah.
There's so much that we're not even touching the surface, I'm sure, to a certain extent, on how the body can perceive so many different factors.
This is definitely more quantum physics, right? Quantum. This is quantum entanglement level of where, one atom is rotated, and at the same time, at the opposite end of the universe, its antimatter is counter-rotated. Knowing these entanglements of atoms and forces are happening simultaneously, we have no idea how it impacts us.
Yeah, that's fascinating. You brought that up, man.
I didn't think I was going to get to that today, but anyway.
Now that you brought that movie Glass, I only seen parts of it, and God, that almost speaks truth to the actual reality. Not even from a superhuman standpoint, but the capabilities of more than likely humans coming into play.
So off that tangent, which I think was a good one, though. I think a lot of people truly do feel this and have met people who have this just extra level of sensational perception, which I'm still trying to understand. But so getting into how pain actually works, we don't have to touch on this too long. I don't want it to be more lecture-like, but I do think this is a great way to really understand pain if you're going to try to manage it yourself and how it actually works. So Melzack and Wall come up with, in 1965, they came up with what was called the gate control theory. And think of pain as this open-close gate concept in regards to whether you feel pain or whether you don't feel pain. So there are things that can actually facilitate the transmission of pain to the brain, which then is important because if the body is trying to tell you that there's something wrong, there are things that need to then facilitate a greater transmission of pain so that you know that something is wrong. In contrast, there are things that inhibit pain transmission, which is important when I get to that here in a little bit. So the theory is that you have this gate control at the spinal level, the spinal cord, where there's messages coming into the cord, and if it's needed to be transmitted to the brain, there's ways of neurotransmitters that will act on the spinal cord to either send it up to the brain or inhibit it at that level so that it doesn't actually get sent to the brain for communication. Now, the way that that works is these pain signals, these afferentative signals, and just afferentation is just a word meaning you have nerves that send signals up to the brain, and those are afferent nerves. And afferentation is all the things that we are experiencing, touch, pressure, all these signals that can basically turn nociception on. And these are happening all the time. Now, the brain's job is to send descending inhibitory pathways down to these pain signals. They're basically meeting head on, and they're doing that the entire time. And so think of it like this. Your body is constantly trying to send signals to the brain, and the healthy parts of your brain is actually trying to stop it. And that's the way the body works. And when you really think about it, when something actually arises and happens that's wrong, there's more signals being sent than inhibitory pathways being inhibited. And finally, once it reaches through and gets sent to the brain, that's when you can note pain is happening. And so the healthy body has pain signals being sent to the brain all the time, which is weird to think, right? It's weird to think that healthy humans have good communication of pain all the time is being sent up. It's not just being sent when you have pain, it's being sent all the time. And in a broken down or altered human, it's when those inhibitory pathways are broken and pain just is constantly being sent through. So without boring you, I hope that is something that you guys can take note of, because one way to make sure that you are stopping pain is how do I facilitate the inhibition of pain? And how do I help try to knock down those transmissions? That's where you're going to start to be able to impact pain. And like Doc said before, the ways that we do that is communication, afferentation. All of these things like movement, touch, pressure, vibration, all that is what actually puts an inhibition on those transmission signals. So, Doc, do you want to touch in on that?
And I think we're trying to come up with analogies on how to explain this better so you guys can have a good representation of this whole concept. And I was listening to a few other people, and some of this kind of came to mind in terms of, let's say there's a knight or a group of knights that are protecting this castle. That is, any pain or enemies trying to come in, imagine the castle being the brain.
Yep.
And there's only one way into the castle through this bridge. So let's say the pain's trying to come back up or go through the gate, go through these knights, these guards, and the brain's trying to suppress it down. It's the exact same situation. So let's say there's way more enemies coming in for the knights to withstand. So they get through, they get to the castle, and then that's the pain perception. Okay. Now, if those guards aren't replenished, if those knights or that bridge isn't rebuilt in terms of either mental thinking, cognitive behavioral therapy, in terms of brain's communication between the body and back, that thus will affect the perception. Thus, if you have poor guards, you may have, in terms of fibromyalgia, in terms of experiencing pain all the time because there's no one to guard your bridge, to guard your enterway, if we will. So
That's beautiful.
I think we can almost play with
that's
that
beautiful.
the whole time.
Yeah, I love that. And, the knights on the bridge could be how we eat, how much you move, It could be the supplements you take. Now, there are other things too. The medication you take gives you more nights. But one way to think of it would be maybe they're temporary nights. They're not going to stay there the entire time. But they're a cavalry until, the rest of your nights come back. So when you start thinking like that, I think it's a better way to approach pain. And that was really good. I really like that, Doc. That was good.
Played with that one for a while.
So
that was good.
I kind of touched on just the factors that can facilitate pain, either transmission or inhibition. Or again, things that facilitate pain transmission, it can be damage of the tissue, it could be negative emotions, stress, anxiety. It could even be just peripheral sensitization, which just means over time, if you think of it like this, touch is a normal stimulus. But if you've ever wore socks for maybe like a really, really long time, and then you rolled them down and you felt your skin was maybe just a little more raw than normal, it's just because over time those nociceptors were heightened. And now, anytime you touch it, you can maybe feel, it feels different than other skin. And that's just this peripheral sensitization. And this can be the feeling of fibromyalgia, this altered sensation that you have over time. It didn't require anything other than your receptors are now heightened or changed some way, somehow, and you're feeling things just off of a normal touch versus,
Maybe for a good example, it's like a superhuman enemy going through the gate up to the castle, and that person or that thing can get back up very easily through the gate whenever it wants to. And it could be due to other experiences. It can be due to other motions, times, places, pressure against gravity, walking, all that.
Maybe it can be invisible. It can walk right through the guards for no reason, and we don't know why.
Yes.
I love this theory. I love this, by the way. This is great. We can continue to play off that. Factors that would inhibit pain, like we talked about, again, affrontation, right? Touch, pressure, vibration, movement. This closes the dorsal horn of the spinal column's gate, thus stopping pain from happening. I don't want to get in too much to the actual neurology of it. Again, positive emotions, distractions. This is also what can inhibit pain transmission too.
We're going to get to some of this with the tools, but how well can your body and brain communicate with one another? And if you have pain locally, whether it's acute pain, chronic pain, if you mess with vibration of like a massage gun, or if you mess with scraping or cupping so you can affect blood flow to the area, that can also affect pain fibers and even the perception of the healing to take place. That all has effect on how your body perceives. Is there pain? Is there damage to the area? Whether there's actually damage or not.
Yeah.
So there's other stimuli that you can go in to a rehab facility, a clinic, see any type of healer, and change certain signals to the brain. Thus will affect the perception of damage.
Yep.
But there's just different ways that you can go about to trick the brain and nervous system of pain or not of pain.
Of finally believing that this area is healed.
Beautiful.
I've even used the analogy of the judge and the lawyer. So the judge is the brain, the lawyer is the physicians trying to help the defendant's pain. Now, the judge is constantly judging, is this joint healed? As a lawyer, we have to continue to rehab, provide a case, which is exercises and chiropractic and all the things that we try to do to build this case up, build the joint up. Finally, the judge says, yes, I understand your case. It's healed. There's no more pain. And
That's a good one.
in a way, that's kind of how I've tried to explain it to patients, where it's like, yes, you've built a good case, but maybe it's not enough. Yes, you've done a great job at changing your diet. Yes, you've done a great job of getting to your appointments, and you've done the rehab, you've done the work, but the pain is still there. What does that mean? Does it mean you need to give up? No, it means you just have to be patient and keep building your case. But don't give up, because that is what's only going to let that pain continue to seep through. And eventually, if you work hard enough, you will build a good case, and you will have something happen. The pain will go down, you will feel better. It may not be 100% back to normal, but a lot of the times in those cases, it's because you had it for 30 years and you didn't really do much over those 30 years to help it. And it's going to take 30 years, or hopefully not that long, but it's going to take a long time to rebuild that case so that your brain actually agrees to say, okay, you've done enough work to actually heal what was damaged at that time.
That's a really good analogy too. Yeah.
Yeah.
I like that.
Yeah.
Okay. How did pain science even start, and how did that evolve over time to where we're at right now? I know you said earlier in terms of the types of pain that we're still learning on how the perception and how the brain processes that pain and all the other areas involved, and how was it handled over the last like 50 years?
Yeah. So before I get into that, I want to touch quickly on acute versus chronic pain, because I don't think we quite hit that, and I think that's important moving on. So acute pain almost always is your nociceptive pain. Tissue damage was done, something happened to where pain just started. Very rarely is something acute that we can't quite understand, unless you just have to do a little bit more digging. That's without exceptions, right? There's going to be exceptions, but most of the time when you have acute pain, it's less than 3 months and just arised. You might have did something, you might have not, but there's always usually some physical change that we can put it upon. After 3 months, maybe even 6 months, that's where we can start classifying this as chronic pain. And in my opinion, chronic pain now has some type of psychosocial aspect. Because if you didn't heal it in 3 months, the brain now has some changed perception of that pain that you now have to also impact when you are treating this pain. And so acute versus chronic, how it's been handled, they've kind of been bunched into one. So any pain now needs medication. Whether it was acute, whether it was chronic, we have it all. No matter what we do, it's going to take care of it. And that's not helpful when you're actually trying to get rid of the pain long term. So they had opium dens way back thousands of years ago. I mean, understanding the types of plants that helped get rid of pain, psychedelics, all these things, this isn't new, right? But synthetic opioids and synthetic analgesics were actually created back in the 40s and the 50s. Now, we didn't need plants. We didn't need to go out and find all this stuff. We are able to just get it out of a pill bottle. So this changed because now we had the ability to go into CVS, Walgreens, pick up this medication because we had pain, take it, goes away temporarily, we're fine until it comes back, right? But we forgot that pain was actually an integral part of the body, and it actually tells a story. It says that something you're doing is not right. And if it didn't go away, it means you're still not doing something right. Still not doing it right. You're still not doing it right. We still have an issue. The brain is still worried. We still have something that we need to address, whether internally or physically. And when we understand it that way, I think it's going to give patients a better chance of creating a long-term effect on pain. Doc?
That's perfect. And yeah, I think it also speaks to the point of the opioids itself. Is it actually treating and helping, or is it the body just feeling that it is helping towards the pain, but it's that relationship between those two, and I think that will come back from the education of the providers. I think it's definitely changing and improving, especially in the last like 10 years.
Yeah.
Based on the opioid pandemic and whatnot with that, but much the same, like you said, there's still a long ways to go. And I think in order to impact the nation, the country as a whole, it's going to take a lot longer.
Yeah.
So it's just time, education.
Yeah.
Yeah.
And through all that, unfortunately, became this greedy cascade of medications, pharma starting to create more and more types of painkillers that impacted different receptors, which then spurred this opioid epidemic, killed millions, got people addicted. At one point, it was 60 people a day were dying from opioid prescribed drugs. And now we are trying to re-educate people on how to actually take care of your musculoskeletal pain.
Yes.
And this has just started. I mean, we have a ways to go to get back where we were on understanding how to take care of ourselves without the use of medication. So when we had talked about the experience part of this, where if you've had this experience or not, how the experience actually occurred, and now that ingrained part of it towards what happened, we are now going to perceive it a certain way. So, Doc, how does the emotional experience towards this episode actually make those changes in the brain, and how does that impact other experiences even moving forward?
Yeah. So what researchers have found is different connections in the brain based on emotional states. What I mean by that is there's a connection between the cortex, or if you can think the outside portion of the brain, and how that connects to the amygdala and the hypothalamus and the hippocampus with the memory aspect. Anytime there's a fearful, a scared, an angry, more of a negative emotion, that then has a higher affinity towards pain, especially with negative experiences. Now, vice versa, anytime there's a happy, a joyful experience, 9 times out of 10 for most people, there's going to be less, if not no, perception of pain itself. So when you look at those two scales and how it can tilt depending on how your day goes, I think a good tool to pay attention to, especially if you have chronic pain, is how can you have the best outlook on life? What are the things that make you as happy and as joyful as you possibly can, and lean towards those during time of injury, whether it's acute, whether it's chronic. If it is chronic, maybe that's a perfect place to start in terms of your mindset. So and that's whether it's, say for example, if you have an acute injury, you can't do something you love, like a sports injury. You have to sit on the bench. Okay, let's take a different approach. What are the things that you enjoy about that topic? And you may not have to experience it, but maybe you can help others better themselves. Maybe you can just observe and learn and try to grow on different parts of yourself based on that sport.
Yeah.
So a lot of it is a mental mind shift, especially when we perceive pain from the brain down. Now this is different, like if it's an acute injury, then there's a nociceptive pathway from whatever injury that you have in the body to the brain, but that starts the cascade of changing your emotional state based on whatever circumstance causes you to feel good or bad.
Yep.
This also even comes to, much like I said in the first part of the podcast, a motor vehicle accident, you rolled, it was a very traumatic incident, and later on in life you just got hit with a fender bender, but you still experience a whole heck of a lot of pain. A lot of that is perceived discomfort from the previous accidents that you've had. And how can you re-regulate those? Some of which, like I said, is going back through the emotions, going back and experiencing those painful, those fearful, those states that cause anger, which can help from a psychological state to calm the system down, which we're going to get here in a second, and Doc's going to do an awesome job. But if you change your emotions, you can change your perception of pain top down.
Yeah. And I love the experience part of it, because I think how I would even explain it to people listening is, if you've had a migraine before, those of you listening, if you've had one, you know what it feels like, and it can be miserable. It can be absolutely 10 out of 10 pain miserable. And then there are those of you that are listening that have never had one. But those that are listening, try to remember what it was like and what it felt like having that migraine. You're going to instantly remember. Maybe you're going to get shivers. The brain is going to already put you back in that experience because it has that connected, like you said, through the hippocampus, memory, everything. It's now changed that way. And those of you listening who have never had one, you're not going to feel a thing. There's going to be no actual integral connection to that experience. And so that's why, in my opinion, experience is so crucial to that. Because how that experience actually came about, how long you had the migraine, what kind of pain you had during the migraine, did you vomit, the entire part of that experience. And if it was incredibly negative, it's going to have such a worsening impact on the pain again.
Even if you were a very high empathetic, too, going back to that mindset, if you have never experienced that headache or that type of pain before, you can have a general understanding, but you're never going to feel experience-wise what that experience is like.
For sure.
So there's limitations to that, I'm sure, to a certain extent. But
Yeah.
Now, in terms, Doc, of understanding the psychosocial factor, because the environmental stressors that one can perceive around you will have a huge effect on how you experience it yourself. But I guess, what is the psychosocial model of pain, and how does that affect, in terms of tools, the betterment of getting the pain under control?
Yeah, absolutely. So I'm going to do my best to not get too much into the science, but I do want to touch on the science a little bit, because I think it'll make some sense to truly understanding pain as we've now learned in the last maybe 10-ish years, 20-ish years. So you have what's called this new biopsychosocial model of pain, where we now know that pain itself isn't just due to a biological or physical structure change. It can, but more than likely, there's now also this psychosocial component of pain too, which is everything we just talked about: emotion, experience, psychological impact, right? And these two can happen together, or they can just happen by themselves. And it's important to know how and what and why is happening, so that we can better assess ourselves and better treat ourselves to get rid of the pain that we have. So first and foremost, just understanding that pain can come from something other than biological is got to be accepted. We have to, as patients, you have to accept that you might have pain from something that isn't a physical change in your body. You might be having back pain without any tissue damage or physical alterations happening in your body at that time. And it's something weird to think about, because in our experience and the way that we've been educated is, when we have pain in our body somewhere, we think that there's something actually wrong with it. And then there might be. Biologically, there might be. But when there isn't, we have to accept that now we might have to approach treating this pain from a different type of management to get better. And that is the beauty of the biopsychosocial model of pain, because now it gives us another understanding of how to treat pain and how to get over this hump of people in chronic pain. Because chronic pain, in my opinion, is poorly mismanaged. We've been having this pain for how long? Okay, maybe it's not the right drug. Maybe we need to do surgery. It's all physical. It's all chemical. There's got to be something physically we have to alter. But that is completely wrong, and we are losing the battle on chronic pain right now. So just understanding that is going to get you so much farther when you're dealing with your own chronic pain. So think of it like you just taking a break, taking a breather. It's important as patients and those listening to understand this, because you need to know where to assess yourself, maybe where you're at in this. It's important as physicians to know this, because if you don't have the tools to manage the patient in the more psychosocial realm, you got to get them there. You got to figure out a way to get them there.
Psychologists.
Yes.
So important.
Psychologists, therapists,
Yes.
people doing more mental health focused things. Boy, that is so underutilized right now, and it needs to be uplifted to an integral part of pain management. And I think in the future, what you'll see is pain management doctors working hand in hand with mental health therapists. I would love to see that kind of model being formed. So there is helpful things out there that I think all practitioners should utilize. And one of them it's called the Yellow Flag Questionnaire. And I'm sure there are other things, but this is just something that I've found to be really helpful. And it's a questionnaire that encompasses questions to help understand if patients are having certain effectors of pain coming from mood, coming from fear, coming from coping mechanisms. And those are really, I would say, the big three things that can psychologically impact pain. So there is a questionnaire that you can take, and the individual score that is added up then gets interpreted, and it gives you kind of a total number of yellow flags. And in terms of healthcare, when we hear flags, we think But red flags isn't, think of it as not, it's not the relationship red flag, where we're not as physicians thinking, oh, red flag patient, we don't want to treat you. That's not what we think of red flags. Red flags is you have something going on that needs further assessment right away because it could be very compromising to your health. Now, yellow flag is if you're having these kinds of impacts towards your pain, it's not something that may kill you soon, right? It's not something that may damage you soon. So that's why it's called a yellow flag. But it's knowing that, okay, do you have a negative mood or anxiety or anger with this pain, which again, like Doc talked about, is going to greatly make this pain worse? Or do you have fear avoidance or catastrophizing or dyskinesiophobia, which all just means, do you fear that this pain isn't going to get better? Do you constantly think about the pain and think, gosh, this is not getting better, and I think it's going to get worse, and it's not, nothing's changing, and I'm thinking about my pain constantly? That's called catastrophizing. And again, it's just continually feeding the interneurons in your body to facilitate the transmission of pain to make it worse. And then we have dyskinesiophobia, which is fear of movement. You are so, like, it's kind of the concept that Doc said about, should you just rest when you have pain? Oh, I'm in pain, I shouldn't move. And if I move, it's gonna make it worse. That is a form of dyskinesiophobia. And that is why a doctor telling you to rest with your musculoskeletal pain needs to be stopped, because it's only making the pain worse. That's why we continually talk about this. So that is more of the fear avoidance. And then lastly, it's coping. It's, have you accepted that your pain isn't coming from biological means, it's coming maybe more from psychosocial. You need to accept that your MRI and the x-rays and the blood work that you did, if they're clear, accept that your pain is coming from an altered perception of transmission in your body. And don't think of it negatively. Don't think, oh, it's all in your head, because too many times people think, and when they go to a doctor, and they think, okay, I got all of this imaging done, x-rays, MRI, blood work, and it was clean. Well, now it must all be in your head. In a way, yes, but don't think of it as you're crazy and we don't know what's wrong with you. And oh, you're just making it up. It's like, no, you're not making it up. We know now. We now know that, yes, it's coming from this altered perception of pain that you're having. And so those doctors that choose to very quickly explain it that way, they're doing it wrong, in my opinion. Instead, they should say, hey, everything is clear. Physically, we don't have an idea to what's wrong with you. Instead, let's take it from the effect of stress, anxiety, social life changes. How are you financially? I mean, these are things that stress, like all the things, like there are just so many things that can impact how we are stressed and have anxiety and psychologically. So that is what's coming in the future, and it needs to, because too many times patients who get into the typical model of pain management, all of what they have in their toolbox is for physical nociceptive alterations. It's I need to poke you, inject you, massage, rehab, chiro, all the things that do make a great impact on patients who have physical changes, but when it doesn't help them, you gotta know where to get them to next so that they can actually take care of this chronic pain. Doc?
And I love how you explained the yellow pages in the questionnaire and how you can break apart the mood, fear, and coping mechanism. There's a couple of easy tools that you can go about that. Like, let's say you go through a questionnaire, it's more fear-based, or it's coping, or just even any of the which, but you almost have to go into the fire a little bit. Because let's say, what Doc, what you just said there, all the tests came back negative, MRI, x-rays, labs, all that. Okay, well, like you said, top brain down, it's probably in the brain. But going back to the experiences, let's say it may stem from an area of fear, whether it's from your childhood, parents, and either going back and having those conversations. And that's where a psychologist comes into play. And it's, I mean, you could go see them. They have a lot of the tools better than what I can probably explain, but the basics are true. You have to go into areas of fear. You have to go into if there's certain movements that you're afraid to go into, you have to go into that exact area. Like I said, if you cause change or you rolled your ankle, you have to rehab in that exact same position in which you got injured.
Yeah.
It's not only physical but also mental too. So those things that you've been avoiding throughout your whole life, those are the things that you have to go back into and explore and understand yourself in that state and those emotions and why you're having them, but being okay that you had them and that it's okay that we're all human.
Yep.
So that's just one part that if you don't want to go see someone, that yes, you may have to go into areas that you're uncomfortable with, that you have to go into these states that you've been sweeping under the rug for
Yes.
decades and years long, and that's where you're going to find a lot of the answers.
Yeah.
So,
And that's the whole concept of exposure therapy, which is
Yes.
a type of therapy that you can do with therapists that get you usually over some type of activity or belief by doing it itself. And like Doc said, this is a great example in my opinion would be, we had a patient who knew that they would get pain while skiing. They were even afraid to go skiing. They had a trip coming up and they were like, I don't know if I can do it, you know? And Doc did a beautiful job and he said, okay, guess what we're gonna do? We're gonna train you while you're in a skiing angle. We're gonna put you as if you were skiing, and that's how we're gonna rehab you. And by and large, did she not only overcome everything, she made it to that trip and didn't even have pain at the end of it.
Had a great
I mean, it
experience.
was
Crazy.
such a fun experience. Is one of the reasons why Doc and I do what we do. It's because we take people who are in these states and we give them the confidence to overcome this thing that they've been dealing with, and even getting them over this hump of fear. And the pain usually goes away quite quickly. It does. It's the actually getting them to get back out and doing the activities they enjoy is the hard part. Because too many times patients get over that pain and they're like, okay, perfect. I'm not in pain anymore. I'm just going to rest. I'm not going to provoke it again. I don't want to get back into that lifestyle. I hated that pain. I'm just going to take it easy for the rest of my life. You better believe that pain's coming back.
Yeah.
Yeah.
And it's a lot of mental effort too. When you go into those experiences and there's no pain, that's a large mental load. A lot of energy is spent on different neural processes. So yeah, it makes sense, but you got to keep on with it.
Yes.
Much like Doc said. So it's that constant progression through the experience. That's why you need that time to change not only habitual patterns, but also mental mindsets, whether it's change of the tissues, body, externally or not. The body works together as a synergistic whole from every external factor coming in. And it's how you can regulate that and have the general understanding that, yes, you're moving towards something better, but they keep moving towards it.
Yep.
That's the never-ending process.
And how to move towards it? Well, there are things you can do in the short term. There are things you can do for the long term. And then, of course, you got to know when should you see a physician to get help, or can you do this by yourself? So, Doc, you want to maybe put your take on that?
Of course, yeah. Whether it's, and going back to what Dr. Addy said, acute versus chronic pain, you have to look at it from a different spectrum. So let's say for acute pain, if you're going to go see a physician, like how bad is it? Whether you scraped your knee, for younger individuals, kids, that is a traumatic experience for them. They oftentimes cry and they look at the parents or who's ever monitoring them as the guardian of how the parents' perception of that is. And I think that is something that can be trained from an early young age to an older age. So like say that the parents come over, and does the parent be like, okay, we got to do this, you'll be all right, versus a parent that is, yeah, you're fine, shake it off, come over here, you're fine, and then change their mental mindset. Then that perception as the individual from a child early on will then get changed throughout life. Now going back to acute pain in terms of a child scraping their knee versus someone that got shot, like there's a huge discrepancy, and there's one side of the scale versus completely opposite, and there's different takes, person dependent, of course, but where on that scale do you perceive that you should go see someone? For some people, it can be on a part of the scale that's earlier on of towards scraping the knee, or let's say they twist their ankle and they want to go see someone. Maybe they're going into a tournament. If you're an athlete, then maybe yes, especially if you want to optimize your system. But there gets to be a threshold to where, regardless if you want to see one or not, you might have to see someone if you got shot. Like there's no other ways about it. So that's kind of how you think you can heal and treat yourself. And the more education you have, you might push that line up higher and higher and higher. Even if you're like a physician or a neurosurgeon and you got shot, you're still going to have to see someone for that. Like there's only so many tools that you can have to where you're going to hit a ceiling regardless. But yeah, Doc, is there anything you have
I
seen
think,
a physician?
I think I like the way you put that on the spectrum, like a spectrum, right? As you continue to educate yourself, maybe have this experience so that way you know what to do the next time. Every experience you have is probably going to then raise that line, like you said. So, when you first roll your ankle, you might want to go see someone. But the second time you roll it, they maybe gave you enough tools, and they should give you enough tools to manage it by yourself if it happens again. Now, you might get to a point where you roll it so bad that you tear something. Well, yes, you maybe have rolled it prior. So now this is a different kind of instance where, yes, you've had it done, you think you can manage it, but if you tore something, well, now you might need, again, go see someone. So it sounds like we're just logically breaking this down, but truly understanding, there are times where when something like this happens, someone like Doc and I are going to make your lives much easier to manage this by yourself, right? And we're going to come from this bias stance where the line that we're talking about is going and getting something drastically done for this issue. We're on the side of it where we would rather have you come and see us first if you need help. And we're going to try and do it in a way that doesn't require such drastic change to the body via medication and surgery. Now, there may be times where, and this is where we get it wrong on pain. It's patient has back pain and they've had it for a while and they've kind of given up. They've maybe tried medication, maybe they've tried PT, and they jump to that threshold now of asking for this help down here, which requires surgery, RF ablation, lasering, burning off nerves. And if they didn't have that education prior to going in, then they're going to be pushed down a path that we find to be more detrimental long term. And so we come to this point of tools because we want you to try to exacerbate all the tools possible, including ours. Let's say you've done it yourself, didn't work, well, come to us because we want to make sure that we can give you any extra tools that you maybe don't already have so that you don't have to get to that detrimental change of anatomy. Because again, in regards to low back pain, it is such a detrimental change. Fusion is, my gosh, you should Google a fusion surgery, man. Like, it's wicked. So, but in terms of tools, Doc, I know we could probably take any condition under the sun and talk about tools, which we really have. If you guys do have an actual wanting a specific tools for each area of the body, we just got done completing the body series. So we went from neck, back, knee, shoulder, hip. We did it all. So if what we say today doesn't quite reach what you're trying to gather, please go back to those podcasts. But Doc, short and the long term, tools that they can maybe hone in on, or at least the basics.
Well stated. And we're going to go into short term versus long term pain. There's a lot of tools that you can use in the whole spectrum of acute versus chronic pain. And Doc, give me your feedback as we go through this too. The first one I have is, especially from a physical side, the brain to body connection of how you can help accelerate the healing of tissues from a sprain, from, to a certain extent, a fracture, to any injury to your body or musculoskeletal system, and how your brain perceives that. Now, you have to have attention awareness. Let's say you're in a sporting event, you injure yourself, there's pain, but you fight through it, okay? That's a different situation versus off the field or off the court or outside the arena to tackle this pain. Maybe wait till then. Unless it's bad enough, that's a whole different situation. But let's say you want to then perceive with no other stimuli coming in, get into a quiet room, get into an area with no other people in it, and just pay attention to that injury. Let's say, for example, we blew out the knee. Looking at it, is there change to temperature? Is there swelling? Is there restriction of movement? Is there pain with the movement?
Color change, like a bruising.
Ooh, yes,
yeah,
good call.
you know.
Just having that awareness will only help the healing of recognizing all that's going on to send resources for the healing to accelerate. But much the same, let's say, okay, we rolled our ankle, we've rolled our ankle in the past, but this hurts really, really bad, but there's maybe no change, or if there is swelling, or if there's minor stuff going on, just sitting and paying attention to that for 5 to 10 minutes at a time. Just even 1 to 5 times throughout the week will have a drastic impact of, are you okay to move in that area? Or is there limitations to you putting pressure on that injured area? And how does that rehab look? So what are the first few stages? Like when you look at the physical therapy route, you want to have better communication to the injured area. And they usually start off with isometrics, or you just trying to squeeze those tissues to have that connection back and forth is drastically important.
Yep.
Like even if you have a fracture where there's particles everywhere, I wouldn't suggest isometrics. And that's where are you at in the spectrum of, is it a really bad injury to where you can't move or walk? Then obviously see someone, find out what's going on. But let's say there's tissue damage, joint damage.
Sprain, strain, something like that.
Yeah. That's when you can start off that light muscle contraction so it can start the rehab process. Now, when I say isometric or a light muscle contraction, there's a spectrum of intensities, right? Like anytime you have an injured tissue, joint, sprain, strains, you want to start off very light muscle contraction, anywhere from 5 to 25%, nice light contraction of that area. Give a couple weeks, and then that will allow you to have less swelling. That'll often allow you less pain, better range of motion, movement. Now then you can add in more of a dynamic fashion to the rehab, and that's usually where you want to see someone for the progression, for them monitoring yourself moving forward. But if you have enough education, you can kind of almost do that yourself.
Yeah.
Now there's other certain situations that you come in, like let's say you injure the joint, or even like sprain strains. You want to have as much communication to that area as possible. So then you'd want to go into joint motion, the fullest range of joint motion. Then, like Doc said, go back to the body series on any of the area. We have what's known as WorkSpaces, or how much you can move each joint in the fullest range of motion possible. This is also known in certain other terms as CARs, or controlled articular rotations. Either or. It's communication at the joint level, which sends the signal of the nervous system to the spinal cord and up to the brain with no delay. Now, if there's any problem going on with the muscles or overlying tissues around that area, there's going to be a signal to the brain, slight delay at it, interneuron, and then kicks back up to the brain. So that's where if we start rehabbing at the joint level and at the muscle level with light isometrics, that will accelerate the whole process moving forward. But it all starts with the awareness. It all starts with paying attention and just focusing on the area, whether it's acute or chronic. If it's chronic, like let's say there's pain at the lower leg. We had a patient that we've used this on before as well, and actually worked incredibly well, to where she had pain in her lower leg for years, and we've done a whole bunch of modalities. We had X-ray, MRI scans. There was no problems at that area. So mainly as physicians, we're thinking, okay, brain down, what is the perception? And then much the same, we have them look and pay attention to that area for 5 to 10 minutes at a time each day for a good 2 weeks. She started noticing that, okay, the intensity started dying down. Okay, the frequency of the times that occurred started dying down. Oh, she's able to walk down the stairs with no pain, which is so weird. In her mind, she's like, okay, I don't know what happened, but I am almost cured. And that mental brain top down had a huge effect in itself. And that's where the awareness comes in the factor.
Yeah.
So,
and for some reason, this popped into my head as you were talking about this, but the brain-body connection, I don't want to go too much off tangent, but I always thought this was an interesting story. So there was a story of a man who was locked in a freezer. And again, this just plays on how the brain can communicate to the body and vice versa. So he was locked into a freezer for, I think it was a half a day or close to a half a day. And they found him dead after the half a day. And the only problem was the freezer was only 50 degrees. So they think that when he was locked in the freezer, he thought it was colder than what it was. He thought, if I don't get out of here, I'm probably going to freeze to death. Catastrophizing might have kicked in. Other things might have kicked in. It started to maybe accelerate certain degeneratory phases of pain. I don't know. Maybe anxiety kicked in, heart rate increased, the heart gave out. Like, the way the brain can change the body is something, again, why we talk about this, why communication between the two is so important. Because if we perceive one thing, then it might alter it. So I always found that such an interesting story. And so when you talk about, like, if it is a fracture, yes, a lot of these times you're not going to start doing these kinds of things, but it doesn't mean that you, and I don't want to say this too, because you will eventually, most people, when they fracture something, you're going to eventually get to a point where the pain isn't going to go away and you're going to go see someone, and vice versa. And if it is truly bad enough, you'll know it's probably sticking out of your skin, right? That kind of thing. But let's say you did, in theory, fracture something, but let's say someone who had enough expertise to convince you of anything told you that you didn't have a fracture, and you tried walking on it, and you had a lot of pain, and then they kept saying, actually, no, you're fine. Like, you don't have, okay, it just really hurts. You gotta keep moving through it. Okay, perfect. I'm gonna keep walking on it. And eventually, that pain, you're going to start to convince yourself that, yes, even though it's really painful, I know that there's nothing wrong because someone keeps telling me that. That person should be you, but if you need someone else to, that's why physicians need to start doing this. You're going to start moving through that. Let's say after 2-3 weeks, I'm not saying do this, by the way, I'm saying this is theory. Eventually that fracture is going to heal. It may not heal appropriately if it's a really bad one, but there are people out there who never got surgery after a bad fracture. They didn't even go to the hospital.
David Goggins.
We see them all the time. Patients come in and we're like, hey, do you know that? You're like, yeah, I had a bad fall that one year, but I didn't think it was that bad. And I'm like, yeah, dude, you definitely have a past fracture, And they convinced themselves there was nothing wrong. Yes, it might have healed in a way that is disadvantageous for movement, but they made it through. The pain came to a point that was far less than when it originally started, and they moved on. That is the connection. That is the ultimate point of all of that we're trying to say, is you can become aware of all these things, and the brain can then, in terms of how you are perceiving it, change upon how you are picking out what's going on in this body of ours.
And I know, like I said, David Goggins, like, he had multiple hairline fractures in his feet as he was running marathons on end. And fractures of bones is going to treat and heal different than any other sprains, strains, any other tears of ligaments, tendons, muscles. So, like, there's differences with all that. But in terms of the pain podcast, we're going to stay with just this concept. In terms of David Goggins, like, when he goes through, you can mentally push through these areas of pain. Like, yes, they're probably causing damage to a certain extent. And yes, bone can heal itself over time. Muscles, tissues, tendons, ligaments, that, unless they get proper blood flow, it's hard for them to, in most areas, heal by themselves, without rest, without building up the tissue capacity around them or the joints.
This is where physicians help,
Exactly.
right? Step in.
Yeah, but the fact that the mind can push through these areas of pain, whether there's damage or not, still allows the capabilities of the brain's control center to the body.
Yep.
It can override it significantly, good or bad.
Yep.
Now, as we go into the next one, cognitive distraction, and we've kind of touched on this slightly before. You can distract yourself and try to occupy the time in which you would go and do that activity and put that time that you're going to do that activity in a different activity that doesn't cause pain.
Yeah, don't rest,
Don't
but
rest.
modify.
Yes.
Kind of like that, yeah.
Absolutely.
Yeah.
So that's one. There's music. The lighter frequencies, and I don't know all the specifics offhand, but let's say that it's more of a calming frequency, that can diminish pain threshold of the brain significantly itself.
Yep.
So how you perceive that pain, and can you calm your emotional state down into a relaxation state, that will diminish the pain threshold significantly.
I didn't even know until I was in undergrad, one of my friends became a music therapy major. I didn't even realize that it was such an emerging field. So when you bring that up, I totally get it. The way she talked about it was incredible. Some of the things and the types of music and how long to play, and like you said, the frequencies. There are certain songs that elicit certain emotions, and which is why we choose to maybe work out to music that's louder, and then of course to calm down. It's like frequencies, tones, everything. And I love that you brought that up, because it's interesting. I know you brought up Marconi Waitlist, yeah.
Marconi Union.
Yeah, there you go. That apparently is one of the more efficient songs to induce anxiety. And they've actually studied that. And I haven't looked into it, but I'm assuming there's research coming out on all the kinds of songs and music that do certain things to the brain and the body. It's fascinating.
Same, but knowing that a song will have a huge impact, and we're going to even try it on an individual coming into the clinic to alter brain state for them to dive in and feel comfortable to go into sleep. But for that individual, they were sleeping in this weird position, like sleeping seated up, and how that can affect just the brain centers, not only from a muscle mechanical standpoint, but also just to dive into sleep. And when I was talking to this individual, she doesn't like the transition from very, very close to falling into sleep to actually sleeping. It's that transition. It's that uncomfortability, and that is where we're going to look to see if we can train to have sound frequencies and have her pay attention to when you get to that state. Just put the focus to the music to see if it can bypass that barrier to get into sleep. And that's where we're going to try to do. So altering with certain states, depending on whatever the restrictions are, I think can help in sound frequency. Even the people that you surround yourself with, from a vibration, energy frequency, has a huge factor. So like, for example, surround yourself with positive people. Let's say, for example, you're in a situation to where you grew up in an impoverished area to where you have no one around you, or the people, your parents, guardians around you, or husband, spouse, wife, have so much negative emotions and feelings to environment. Well, you have to get yourself out of there. One, or two, you have to have high amounts of discipline to have strong self-talk to alter those states. And just, I think one of the best ways, if you find yourself in that standpoint, we are lucky to even be alive.
Yes.
I think there's a quote that's, I thought about, I don't even know who came up with it. Is maybe I did, I don't know. But life will be hard. It'll be fun. You'll cry, you'll laugh. But one thing is for certain, you're lucky to be alive and breathing. At all odds, we're 1 in 400 trillion to even breathe and be alive. So for such a short period of time on which we can experience living on this earth, for as much that we can accomplish and do, there has to be a mental mind shift of being grateful just to breathe, to experience. And yes, you may have to come up against challenges, but being able to even have the opportunity to go into those challenges and look at it from that perspective, I think can help anyone at their darkest moments come up against a Goliath, if we will.
Yes.
So Now, let's say we want to try to combat pain from an external source or the body. Heat, ice can work to a certain regard. Ice, if you numb the area, can have a diminished signal to the brain, but with ice, it also allows less blood flow in and out, lymphatic tissue of waste products to get filtered out. And that's also, again, paying attention. Like, you can use heat versus ice for most people, but it can only last for so long.
Right.
Now, let's say we want to use heat. That can soothe, calm the area down. Usually for arthritis, it works really, really well. That's where hot tubs, sauna, and for other factors can get put into the equation. But that's just the perception of the healing at the external source or the body. But the brain's perception will alter also with a cold stimulus. So, for example, if you have a cold or warm stimulus, the internal core body temperature, which gets regulated through the thalamus and up to the brain, also has a very close connection to pain. That can be regulated on only 3 areas of the body: the palms of the hands, the bottom of the feet, or your forehead. It's just glomerulus cells that alter and change the internal core body temperature signaling. And we've said this probably in other podcasts before, but you can do more work if you limit the barrier of increasing the internal core body temp, which can allow you to do more work. Much the same if you are in any other stressful situations that are ramping up and causing anxiety and stress, you can cool and decrease that temperature. And it almost seems counterintuitive, but even neurosurgeons give out the tool of, if you're having a panic attack, you have to combat that high signal stress of that mind with another stimuli, just so you're able to calm the system down from the awareness factor. So they say that you put your hand into an ice cold glass cup container for 20 seconds to a minute will help calm the system down, almost catch your breath up, because it changes the signal of the brain to the external stimulus, which is usually just as equal, which is just an awesome tool in itself.
Yeah.
So, I mean, there's that from the heat versus ice standpoint. Now, let's look at it from a nutritional standpoint. Let's say you have an acute injury, or if you have a chronic injury that you've been trying to overcome for longer periods of time. Well, not only from an environmental standpoint of your surroundings, but also the internal state going outwards to your nervous system and to your body, its perception. High sugary foods, processed foods will diminish the signals out to your body,
Yep.
and it's not going to allow proper healing stages to occur from acute or chronic standpoint. Yep. Thus, when people have injuries or they're coming to see us, diminish high sugary foods, diminish processed foods, so the body can re-regulate itself much easier.
And when those resources aren't there, healing won't happen. And when the body almost heals something, there's now again, like Doc said, a different perception of that area. So when it's not fully healed, the brain thinks, well, I do have my joint still, but it's not a stable joint. It's still probably weaker than other joints, and there still might be damage there left to be healed. So I'm going to keep that pain signal on until we fully heal that joint. Well, the problem is the body is saying, I'm done. I want to give resources back to what's going to keep me alive, which is pumping my heart, digesting, breathing, which is way more important than healing that knee right now. And I think that's the theory that I always like to go off of, which is why is chronic pain even a thing? And I think it is. Most of the things that I've read is you have this healing cascade that starts, like we talked about last, which is, platelets first and stem cells come in. But if it isn't truly healed at the end, it doesn't just start over. It's done. And whatever tissue was laid down. And whatever scar formed was formed. But once it's formed, the body doesn't go back and say, oh, that scar is crap tissue. Like, let's eat that scar away and put brand new tissue down. We would love for that to happen, but it isn't. It's a one and done. It's whatever is going to be healed at that time is going to be done, and you're left with that. So the nutrition is that portion of resources that if something like that were to happen, it's our body's best chance to heal when needed. Yeah.
That's went really smoothly. Now let's go into sleep quality. So when you look at the quality of sleep that you find yourself in, that's when you're in deeper stages of sleep, like stages 3, 4, REM sleep. There's a lot of growth factors going. There's a lot of healing and re-regulation of your whole body, and also parasympathetic system for the rest and digest, if we will, that whole system. So ideally trying to increase the amount of sleep that you get. If you can improve the quality of sleep, even better. But like, let's say you have an injury, ideally I want that individual to take naps, especially on weekends, and that'll help almost combat just resting it and not performing other therapies. How well can you sleep at night will have a huge correlation factor. But let's say this pain doesn't allow you to get into sleep. That's where then you might have to go at other therapies or other tools of nutrition. You might have to go in other therapies of going and seeing a physical therapist, chiropractic, for the healing state of the external body back to the brain. But if you can get as much quality, high sleep, as much sleep as you can, especially with an acute injury or you're starting the rehab process for a chronic injury, highly suggest.
I think in some physicians' hierarchy of order, I think sleep is number one for a lot of physicians. If you're not sleeping, you're not healing. And I think I would even put sleep at number one for myself, just because, like I've said it how many times, if sleep was a drug, they'd patent it and make millions, billions. It'd probably be the most sold drug on earth. But too many times we deprioritize sleep, and we forget how important sleep is, not only with just energy and rest, but so many other parts of health. And I think there are too many times I've found patients to deprioritize sleep for other reasons, and it only hurts them in the long run. And when we go to sleep, growth hormone is heavily risen, which then helps to grow and heal and repair, and that's exactly what healing is. So why do we need to prioritize sleep if we have pain? Exactly that. We need to grow and repair and heal.
And even if you don't have time, like let's say you're a busier individual, you have a lunch break, instead of taking a nap, maybe go into a meditative state to calm the system down. Like they seen this with yoga practice called Yoga Nidra, which if you do that 15-20 minutes, gets you to a calm state, which will not only help for neuroplasticity and relearning of any new material, but it also allow for getting into the first stages of sleep. Whether you're completely into sleep or not, that will help calm the system down and allow for proper healing properties to start to take place. But that is another good tool as well. Now, I touched on this earlier on in terms of exercise and getting movement from the communication from brain to the body and body to the brain. So ideally with exercise, you don't want to move into any areas of pain, but to actually involve movement of the body, or even for that matter, other muscle contractions of other areas of the body that aren't in pain or don't have an injury. What I mean by that is, like, let's say we roll both ankles for this simplicity term, and we want to have the healing to accelerate. Well, one of the ways that we can do that is by increasing blood flow to the body. So maybe not addressing or working on any of the tissues in the lower body, legs, but maybe doing muscle contractions, the arms, of the wrists, the forearms. That automatically will send blood to the body. Or if we do any type of upper body exercises and have more rest or healing and rehab for the lower body, legs. Like, you can play with different areas of the body just as long as we increase blood flow is the main topic to this. And if you're able to, even go into areas of light, low-level cardio will also accelerate blood flow to the whole body as well. But,
you want to pick out the 1,000 benefits of exercises. You know, you're going to have them. But specifically for pain, exercise, it boosts mental health. So when we have better mental well-being, again, we talked about how that's going to impact pain. Blood flow to heal, like you just talked about, it's going to impact healing, going to impact pain. You're going to talk about affrontation. When we move, again, improving that signal. It's going to decrease pain. I can go on and on, but really when it just comes to pain, those are some of the key reasons why we talk about, it's not just to talk about it. You break the things down, there are many benefits to that, many benefits.
Now going to the last one I have is pain diary. Now, not only will this help you understand correlation between the pain that you experience and the time that you experience it. Do you have pain when you are seeing friends or this individual? Are you having pain in this setting or with this activity? Or you ate this food, drank this drink, and you experience pain. Like, you have to look at everything. So when you have a pain diary, when you're experiencing that pain, I want you to pay attention to every factor around you, the time of day, the people, the environment, the setting, what you ate previously, and is there a trend? I think for your perception to put the pieces together, is there a correlation between that pain and other circumstances at the same time? And then either one of which, doing that yourself or having a physician monitor that with you, will also have a huge correlation factor. But let's say, for example, you're going through a pain diary and there's certain memories that pop up or conversations that you may have with an individual. Maybe it's not that person, but things that get brought up that can help cause anger, aggression, fear. And then what we know is the anger, emotional, negative state will have a direct correlation to pain. Okay, so let's dive into the areas of pain and try to handle that emotional state. You either have to go into that area of fear and experience it and perceive that, okay, it's okay to get into that state, or combat that and to diminish that threshold. So we see this in veterans to where they come back from war, they come back from all this traumatic instances that they experience, and any other setting in normal state that is more safe, if we will, that any other loud sounds or a lot of people in an environment can set triggers off. The more exposure that you have to the area in a safe place will help diminish the threshold of your perceived experience in the past. I think it's probably the best way to say that, but yeah.
And the only thing that I kind of want to touch on with that would be, you'd be surprised at what you are hypothesizing about your pain that you might find out is completely wrong, a wrong hypothesis, which would be, when I use, the only time it gets worse is when I use the stairs. It's like, okay, so let's say your pain was worse that day and you used the stairs. Well, let's say the next day you chose to not use the stairs and the pain was the exact same. You didn't use the stairs that day, but it was the same as when you used them the other day. Well, then what? Now what's your argument? Is your argument that it's only when you use the stairs, but your pain is the same? Well, now that's not the fair argument. Now what? The what is, it's not always that. It's something way more different than you need to think about. It's the amount of time you're sitting. It's the amount of time you're thinking. It's what you're eating. Again, everything that you just stated. What is the setting? What is the environment? And to really end it is, sometimes it's more than one thing. It's not always the one thing. And too many times we get so stuck in the tunnel of ones, right? So it's like, okay, I tried to exercise, well, that didn't work. Well, now let me try therapy. Well, that didn't work. Well, now let me see if I can't eat a little better. When really, it's probably all those things. And all of them have somewhat of a part into that. So what's the ultimate goal? Well, that's everything we've been talking to you about for the past 6 to 8 months, is you got to take care of yourself from an overall holistic mindset. That's what's going to keep a lot of this pain away for the longest of times.
If you have any questions, comments, concerns, by all means, please leave them below. We'll either do a short series video to address those concerns, because pain science is a topic that there's so many small nuance situations that can come up and topics that are playing off one another. Like we said, there's a biopsychosocial model. There is not only pain that can come from the brain to the body and body to the brain. Like, everything works as a whole. So if you want to dive into this more specifically, either one, come see us. If you don't have the capability, then go see someone that will have a general understanding of these external factors just as much as the chief complaint in which you come in for. I think is a good place to start.
Yep. Perfect, guys. Well, thank you guys so much for listening. We appreciate each and every one of you. And we're just, again, extremely grateful for this opportunity to continue to give you guys the knowledge that we have and what we find. So until next time, we'll see you guys soon.
Thanks for joining us on The Functional Code. For more evidence-based health insights, subscribe, rate and review wherever you get your podcasts. Remember, your journey to a healthier you begins with understanding the functional code. Until next time, stay well, stay informed, and embrace the science of living well.